discussion on host exam trial on clopidogrel versus aspirin in post-PCI with DES patients for maintenance therapy. Host exam trial was an investigator-initiated, prospective, randomized, open-label, multi-center trial. The study had 37 sites in South Korea. It was a head-to-head comparison of efficacy and safety of aspirin and clopidogrel as monotherapy during chronic maintenance therapy in patients who underwent coronary stenting. The highlight of host exam trial was that it showed that clopidogrel monotherapy was superior to aspirin monotherapy as chronic maintenance therapy among patients who have completed the required dual antiplatelet therapy after PCI with DES implantation. The study enrolled patients who were on dual antiplatelet therapy for 6 to 18 months after PCI with DES without clinical events. Those who had any ischemic or major bleeding complications were excluded. Patients were randomly assigned to clopidogrel 75 mg or aspirin 100 mg once daily for 24 months. Primary composite endpoint included all-cause mortality, non-fatal myocardial infarction, stroke, readmission due to acute coronary syndrome, and BARC bleeding type 3 or greater. It was an intention to treat analysis. 5,438 patients were randomized, and ascertainment of the primary endpoint was completed in 5,338 patients. Primary outcome occurred in 5.7% patients in the clopidogrel group and 7.7% in the aspirin group. All-cause mortality was 1.9% in clopidogrel group versus 1.3% in aspirin group, which was not statistically significant. Non-fatal myocardial infarction was 0.7% versus 1.0%, which was also not statistically significant. Stroke occurred in 0.7% of the clopidogrel group and 1.0% of the aspirin group, which was statistically significant. Readmission with acute coronary syndrome was 2.5% versus 4.1%, which was also statistically significant. Secondary thrombotic outcome was a composite of cardiovascular death, myocardial infarction, readmission for ACS, and stent thrombosis. It was 3.7% in clopidogrel group versus 5.5% in aspirin group. Secondary bleeding outcome was any bleeding, which was 2.3% with clopidogrel and 3.3% with aspirin. The authors concluded that in patients requiring indefinite antiplatelet monotherapy after PCI, clopidogrel monotherapy was superior to aspirin in preventing future adverse events. One important limitation while generalizing the data for global population is the geographic limit of the study, which was conducted in one country. Open label nature of the study is another obvious disadvantage. Clopidogrel resistance was not assessed in the study. This study is hypothesis generating and calls for a multinational double-blind comparison on a larger scale to get a better conclusion on long-term antiplatelet monotherapy after PCI with DES. A somewhat similar disadvantage for aspirin was suggested in the AUGUSTUS trial among patients with atrial fibrillation and recent ACS or PCI. Adding apixaban to P2Y12 inhibitor resulted in lower bleeding compared with vitamin K antagonist and a lower rate of death or rehospitalization. Addition of aspirin resulted in greater bleeding without any difference in efficacy. 92.6% of patients in that study was on clopidogrel at randomization, while only 1.1% was on prasugrel and 6.2% on ticagrelor. But in the AUGUSTUS trial, there was no head-to-head comparison of aspirin versus clopidogrel or any other P2Y12 inhibitor. There was an aspirin versus placebo comparison, while there was no P2Y12 inhibitor versus placebo comparison.